All right, good afternoon, everyone. My name is Juan Teran. I'm an assistant professor of medicine at the Division of Infectious Diseases at UNMC, but most of my work really is the medical director for Nebraska ICAP. So I mainly provide infection control support to different facilities in the state, and I also work with stewardship with the ASAP group. So the topic of today is really the fundamentals on how to manage the most frequent infections in long-term care settings. Those are the big three of long-term care. That is urinary tract infection, a skin and soft tissue infection, and respiratory infections. So I don't have any disclosures. I don't have any conflicts of interest. And my objective by the end of this talk, you should be able to evaluate the impact of some stewardship interventions for UTI, for respiratory infection, for skin and soft tissue infection, how to apply evidence-based interventions regarding antibiotic treatment for these conditions, and how to collaborate effectively between infection control, maybe your consultant pharmacist, to improve outcome. Just to gauge the room, how many of you are IPs, infection preventionists? Got it. How many of you are consultant pharmacist? Okay, got it. How many of you are nurse practitioners? Okay, I see a couple of hands. And anybody, medical providers, doctors? I see one. Okay, so this is going to be very clinical. I'm going to show some clinical scenarios, especially targeted for somebody who's fairly new to long-term care on how to approach this. So I'm going to talk most of my time about urinary tract infections because I'm going to use some of the concepts with this diagnosis, and those will be applied to respiratory infections and the skin soft tissue afterwards. But I wanted to make it very clinical. So let's start with a scenario. So you are a newly hired IP at a 50-bed skilled nursing facility. Compared to your prior job, you see some gaps in stewardship. So there's no written statement of support for leadership for stewardship. They don't have any FTE dedicated to stewardship. And right now, the only current practice is that the consultant pharmacist will do some antibiotic timeouts. But really, they don't have a ton of FTE. This might sound very familiar. It happens in many facilities. So you recognize the gaps and you think you should talk to leadership and make your case that, hey, we need a little bit more support for stewardship. How can you make your case? How can you convince leadership that you need some FTE and some support? Why does it matter? It matters because 70% of nursing home residents will receive at least one or more courses of antibiotics in a year. That's 7 out of 10. That's quite frequent. And the same as acute care or outpatient, about 45 to 60% of those antibiotics are really inappropriate prescriptions of antibiotics. So we can do a much better work in less use of antibiotic therapy. So sadly, in long-term care, we don't have as much data for antibiotic use. It's not like acute care where you can get NHSN reports for your antibiotic use, days of therapy. You can compare to the national average and get what's called a SAR, a standardized antimicrobial administration rate. You don't have that luxury here in long-term care. So you got to make do with the data that you have. And I like this study. This was organized by CDC. They wanted to see on average how many people are receiving an antibiotic on any given day on a long-term care facility. So they look at 10 states. They recruited 161 facilities, a total of 15,276 residents. So big, a large population. And they found that on average, about 8.2 out of every 100 residents are receiving an antibiotic any given day. That's quite a big number. And it's not random who gets the antibiotic. They decided to do some analysis, and the biggest risk factors, and you can see that on the title, is those that were recently admitted to your facility, those that are going to be a short stay, and those that have medical devices in place are going to be the most likely to be exposed to antibiotic therapy. And we know that there has been a shift on the population that goes to long-term care. If before 2000, you would have your senior resident that's going to stay for more than 2 years in a skilled nursing facility. But now with CMS realizing the cost of having somebody admitted to the hospital for so long and trying to improve value-based purchasing and try to move people out of acute care hospital quickly, long-term care is really lifting the burden of that of people have to go somewhere and they're going to long-term care and they're going with antibiotics and they're going with risk factors and they're being colonized by multi-drug resistant organisms. So this kind of reflects the why we're seeing more antibiotics. And if you see, for example, if you are a short stay resident, you have a 40% higher odds of receiving an antibiotic than if you're going to stay for a long time. Or if you have a central venous catheter, that's quite a big number. You're 11 times more likely to receive an antibiotic. Or if you have a catheter, a urinary catheter, and that's quite frequent, you're twice as likely to get an antibiotic than somebody else. If you were admitted within 30 days, you're 3 times as likely to get an antibiotic therapy. If you're outside of the city, you're a little bit more likely to receive an antibiotic as well. So it's not random who gets the antibiotics, and this can focus your work on who should I pay attention to. Um, and the big three of long-term care. Here you can see for which conditions people are receiving antibiotics, and it's urinary tract infection, skin and soft tissue, respiratory infections. But also interesting, 18% of those who receive antibiotic are receiving it for prophylaxis to prevent an infection, and about half of those are mainly for UTI. I'm pretty sure you see it in your facility, a lot of people with UTI prophylaxis on the same antibiotic for a very long time. Is it effective? No. We'll talk a little bit more about that. So also people going from acute care to long-term care. This is a study from Oregon. They saw from people going to the hospital, they follow 6,000 patients going to long-term care, and 22% of those were living on an antibiotic, and not always antibiotics that we, for example, we try to avoid, like quinolones. 22% of those, 20% of those were receiving quinolones. So people are going to your facility and are going on antibiotic therapy. So you can show that to leadership, but perhaps what's gonna, give you the best story to tell is if you show them your own data. And there's many ways that you can do that, and there's gonna be a session dedicated to that on tracking. But you can do the same thing that CDC did. Just look on any given day how many residents are getting an antibiotic. That's a very powerful story to tell. But even better if you can get continuous data. For example, antibiotic starts per month, per quarter, days of therapy. If you have those two, you can divide them and get an average duration of therapy. If you can divide it by provider, you can see maybe who needs a little bit more assistance, or if you're collaborating, for example, with ASAP, we are helping some facilities to get benchmarking data. You can see how you compare to your peers. So the more data you have, you can make an ask to leadership. This is why we need it. Um, so we know why it matters. So you went to leadership. The meeting went great. They said they said that they are very concerned of how much antibiotic is being used and how frequently is inappropriate. So they asked you to do some kind of interventions for UTI. How can they improve the diagnosis and maybe implementing an SBAR? So there are several options on that discussion, and people were talking about McGear. They were talking about Loeb's criteria. So what would you do? Would you use an SBAR using McGear? Would you use an SBAR using Loeb's? Or you think medicine is complicated? Let's have our medical providers do what they need to do, but documented, or you're not sure what's the difference between A and B. So that's a great place to start. What is the difference between Loaves and McGear? You've seen those names, you've used some of those. Well, Loave was designed mainly as a clinical criteria, while McGear is more of a surveillance criteria. So when you talk about a clinical criteria is to make a decision at that point with the information you have at that moment. You probably are not going to have culture data. You're just going to have your vitals, whatever the resident is complaining about, and you need to make an informed decision. So low criteria is giving you some signs and symptoms that if positive, you have a reasonable expectation that there is an infection and antibiotics might be appropriate. So if you're looking to improve diagnosis, that's where I would go to. While McGear is a surveillance criteria, so you want to count the true events just to paint the story of what is the prevalence, what is the incidence of this diagnosis, how often it happens. You want to make sure you capture the right diagnosis. So they use things like signs, symptoms, but also surveil cultures. So something that you wouldn't have when you first see the patient, McGear uses that. And here's an example of McGear for UTI is asking you, you must fulfill both one and two, one being clinical, but two being those cultures. So useful, but it depends on what you're looking for. While Love's minimum criteria is what most of you should be using in order to diagnose residents. And for example, in UTI, is making it very easy for you to divide it in those who have a catheter and those who don't. Because really the symptoms are very different between those two. And when you have criteria, well, then you can guide what's going to be the next step in management. And what they're doing is dividing by no catheter and catheter. And let's start with no catheter. The urinary system starts with the kidneys, produces the urine, goes down to the ureter, goes down to the bladder, and finally to the urethra. But that's not how bacteria enter the body. They enter the opposite way. They enter through the urethra many times because of a bacteria that comes from the GI tract and then goes up to the bladder. And that's where you're going to have those signs and symptoms. You're going to have burning with urination because the bladder is irritated, the urethra is irritated. You're going to have frequency. You have to go all the time. You feel like you cannot empty your bladder. You may have incontinence in your resident. As the infection is going up, then it's starting to hurt on the side. It's going to be what we call CBA tenderness or flank pain. And if it reaches the kidney, is when you're going to see your more symptomatic and more severe infection with fevers, rigors, and can also be delirium, acute onset delirium. But if you think about catheter, it's a little bit different because now you have a foreign object into your urethra, you're bypassing that. So you cannot rely on burning with urination or urgency because they're not peeing, they're emptying it through a catheter. So you're relying on maybe suprapubic pain, that pain when you press the lower portion of your belly. And then higher up is the same as somebody without a catheter. So now you have your criteria, you can make a decision. And this is a great tool that you can print for your providers, is from the Agency for Healthcare Research and Quality, AHRQ. If you have criteria, then you can make some decisions like, do I send a urinalysis? Do I send a urine culture? Do I increase fluid? Do I start antibiotics? But I want to make sure that you notice that why some things I didn't mention, and we shouldn't be sending cultures for people with foul smelling urine. Urine is going to change in odor because of the things that you eat, because of how much you drank that day. Um, if it's cloudy, it's not a marker of infection. It could be just because your catheter is colonized with a lot of bacteria, it changes color. So it's not a marker of infection and it's not going to be a good indication for a urine culture. Also, when you change a catheter, no reason to send urine culture unless somebody's symptomatic. Also, when somebody goes to your facility for admission, no need to take a urine culture, no need to do a test of cure after UTI treatment, and no need to take a urine culture every time somebody has altered mental status, because that's quite frequent. And it's better to do what's called careful surveillance, that you have somebody you monitor, you take some vital signs, and if you cannot explain it any other place, then yeah, you might do some cultures, but in most people, they won't need it. And the reason why we don't test people as much is because asymptomatic bacteriuria is very common. Asymptomatic bacteriuria is when you have bacteria colonizing your urine tract, but you don't have any symptoms and there's no infection. And here you can see this is from IDSA. And for example, the group of elderly persons in long-term care facilities, up to 50% of them will be colonized with bacteria and they don't have an infection. People with a spinal cord injury, up to almost 70% of people. And if you have a long-term catheter, you have bacteria in there. So, and we know that treating that has not really improved outcome or prevent infection and really drives resistance in organisms and side effects from medication. So now you know the difference between McGear, you know the difference between Loeb. So you implement a very successful SVAR. This is an example for Mr. Walker. He has the situation is I'm concerned about UTI. The background, he has a catheter, is urethral catheter. He had a UTI 6 months ago. They treated him with Keflex. He doesn't have any allergies. These are his vital signs. And this is the criteria that he meets. So now you have a more organized and a better way to diagnose this patient. Um, if you go down, you see that the protocol was met, and this is Nurse Debbie Summit who sent it to Dr. John Stewart, and he reviewed and he said it's reasonable to send testing and it's reasonable to start antibiotics, and we're going to change the Foley before taking our cultures, and we're going to treat these gentlemen. So very successful implementation. And so let's go to back to our clinical scenario. So after implementing your UTI SVAR based on Loeb's criteria, you educated the staff because making changes is difficult for a facility. So you take a couple of months on showing this new tool, and now you see a 25% reduction in antibiotic starts related to UTI. So kudos. And leadership is very pleased, and they allocated some FTE to you because it's really making a difference. And you are checking some SVARs to make sure things are going okay. And you run into the SVAR of Mrs. Barnes. She's a healthy 63-year-old woman. She doesn't have a catheter. She met Loeb's criteria because she had burning with urination, urgency. She had blood in her urine, and she was started on nitrofurantoin or macrobid for 7 days. And you check on Mrs. Barnes on day 3. She's not better. She still has the same symptoms. The urine culture actually didn't grow a single bacteria, but nobody has made any changes. So, what would you recommend? Would anybody go with continued treatment because antibiotics may take a little bit of time? No, I don't see anybody. What about asking your medical director to maybe give the patient broad spectrum antibiotics because it's really not helping? No, everybody wants the right answer. That is, let's do a timeout. Let's see what's going on with Mrs. Barnes. So now you have a new document that you're starting to use in your facility, and now it's a timeout. So my situation is I'm calling for a follow-up for Mrs. Barnes. She's on nitrofurantoin twice daily. It was started 3 days ago for UTI. The vitals when she was first seen were stable. She met Loeb's criteria. And my assessment now is that the vitals are still okay, but she has remained the same, and the culture has no growth. So now you send it to Dr. Stewart again, and he says, hey, I took a look at the chart, and she has kidney stones quite frequently. So I'm going to stop the antibiotics, and I'm going to send her for a CAT scan, and I saw a stone. And now you acted on information, and you're doing timely decisions because when we first meet a patient, they might look like an infection, but after a few days, you will have more information. You'll have your cultures, you'll see how they responded. And now, instead of having 7 days of antibiotic therapy, you only have 3. And now you're looking for the right diagnosis. So implementing a timeout is one of the most effective things that you can do for stewardship in your facility. So Let's go to our clinical scenario. So now you have your SVAR for UTI, now you have your timeout, and you are reviewing the urine cultures because you went to the last session and you know that cultures sometimes show interesting things like ESBL organisms. So you're kind of curious to see how many of those you see in your facility. But you observe that a quarter of your urine cultures, so 25% of them, are contaminants. It says that they have more than three organisms and that they are not going to speciate those. And on further investigation, you saw that, hey, we don't have policies and procedures on how to obtain urine cultures. So you decide to audit the collection practices in your facility, and you see the first one, Mr. Watkins. He's 70-year-old man. He has prostate cancer, and he has some obstruction, so he needs a Foley catheter. He's exchanged every 4 weeks, and last was exchanged 3 weeks ago. He has flank pain, he has fever, so now you know he has Loeb's criteria. A urine culture was ordered. The chart note says that urology is fine if you exchange the Foley in your facility. So the nurse does that. So she exchanges the Foley using a septic technique. You actually went to the room. There was good hand hygiene. You're very proud of that nurse. The catheter was clamped for 15 minutes. Sterile gloves were done. Um, the catheter port was clean prior to aspirating the urine. You got 5 mLs of urine. You put it in a sterile container. You labeled the name, the date. You put it on the desk. You call the regional lab. They're going to pick it up in 2 hours. Does anybody notice anything abnormal with that practice? Looks perfect. Otherwise, looks perfect, right? They did all the aseptic technique, all the right things. 2 hours, that's kind of long. Now you have some bacterial growth, and maybe your culture is not going to be as representative. So this is from again, from AHRQ, some of the best practices. Pretty much everything we said, except you should take your cultures within 15 minutes to the lab. And if you cannot do that, then put it in the fridge to avoid any growth on the cultures. So and the reason why we want to exchange catheters many times is because of biofilm. This is an electron microscopy. You can see the bacteria, those kind of wiggling figures. And what they do when they attach to something foreign is they produce biofilm, which is a mix of proteins and glycoproteins. They're making a nice nest in that Foley catheter. They're being protected by this biofilm. And the problem is, if I test with the same Foley catheter the patient had placed 3 weeks ago, what I'm going to test is the bacteria on that biofilm, not necessarily what the patient has in the bladder. And even if the patient has a real infection, placing a catheter sometimes accelerates the rate of resolving that infection and symptom resolution. So very important for somebody with a catheter that if possible you exchange it before obtaining cultures. That's going to make a big difference in the way that you diagnose UTI. So now let's see another patient, Mrs. James. She's 65-year-old woman. She had a hip replacement because she had a fall. She fractured her femur. She can bear weight for a few seconds and maybe she can walk with assistance to the bathroom. She's complaining with burning with urination. She also has some frequency, some suprapubic tenderness. So she has Loeb's criteria. So you want to get a urinalysis and urine culture. What would you do? Would you do clean catch and midstream collection, but she's having pain? Maybe I shouldn't bother her. Maybe would you give her a toilet hat and just get that urine and put it in a container? That wouldn't be the best option. Toilet hats are great to measure eye and nose, but they're not sterile. They're going to get contaminated. Maybe I do an in and out catheterization. Great option, but it's a little bit more invasive. Maybe you offer to catch the urine while she's trying in the bed. No, you're going to contaminate yourself and the sample. So really, a gold standard would be to obtain a clean catch with a midstream sample. And AHRQ again, best practices, you want to make sure that the resident take a bath or at least use a sponge with soap and water before obtaining that sample. And if you can, you want to get the midstream clean catch. So you want to remove that first part of the urine because that's going to be colonized with bacteria from the urethra, from the genital area, and you want to get the most yield. And if you have to do in and out of catheterization, you want to clean the genital area the same way. You want to use a sterile technique. And if the patient is a man, you can also do a condom catheter, but you should be checking every half an hour because the same concept, if the urine stays there for a long time, is going to get contaminated again. So perfect. Now you improve and have some policies and procedures. And you're also reviewing the antibiotics. Now you have some IT support and you're working with a consultant pharmacist. And while reviewing the antibiotics in your facility, you notice that the average duration of therapy is really long and is mainly because it's skewed by 8 residents. They're all on continuous antibiotic for prophylaxis for UTI. And you see that seven out of those women, 7 of those are women over the age of 55. One is on vaginal estrogen, one is on methenamine, but that lady happens to also have a suprapubic catheter. One is on cranberry. So based on this data, and you remember the data from the CDC that 18% is prophylaxis and half of that is for UTI. So that's about 8 to 9%, but you have 16% with continuous prophylaxis. So you think that's kind of high. So what would you do? Would you continue current management because UTIs are dangerous and the benefit outweighs the risk? You want to start cranberry on everyone. You want to leave vaginal estrogen to the PCP, or do you want to work with your pharmacist to create a prophylactic antibiotic audit? Hopefully, most people are thinking about the last one. So let's talk a little bit about the data on prophylaxis. So let's talk about vaginal estrogen. The option was to leave it to the PCP to talk about vaginal estrogen, but I want to challenge that idea a little bit. This was a very nice study. It was called the Empower Survey. They decided to send a survey to 2,300 women over the age of 45, at least almost 1,858, so almost 2,000 of them had at least one symptom of vulvovaginal dryness. And you can see the symptoms there: hot flashes, vaginal dryness, and urinary issues in 20% of them, and having occasional urinary issues in almost 40% of them. So it's quite frequent. And if you see on the survey, 56% of women have never discussed vaginal symptoms with a healthcare provider. That's a staggering number of people that haven't discussed that with their medical doctors. 85% of women who spoke with a doctor is because they brought it up. And so it was never brought up by the doctor. And for those who discussed treatment, only 46% were offered the option of a hormonal treatment. Most of them are just offered over the counter lubricants or moisturizers. And more alarming is that healthcare providers mentioned to 20% of women that um, these symptoms are part of aging and they should just learn to live with it. And that's really not acceptable. So I would argue that maybe you want to encourage as many women that have recurring UTIs in your facility to think about vaginal estrogen. And the data, maybe going through too much of the data is beyond the scope of this talk, but I want to talk about a few of the interventions that we have. The first one is vaginal estrogen. Two studies that I want to mention. The first one is from Simonik, and what they did is women that were not on vaginal estrogen, they saw that 23% of them develop a UTI within the 12-month period. After they started using vaginal estrogen, only 6.2% had symptoms of UTI. The next one is a study from Ross. And after they started vaginal estrogen, about 95% were UTI free for 4 months, compared to only 30% that didn't use vaginal estrogen. Those are great numbers, and it's a great way to spare antibiotic use just by using vaginal estrogen. The other medication that is great is methenamine hippurate. So methenamine kind of goes into the bladder and kind of denatures and affect the bacteria so that it doesn't allow it to grow. Uh, the data is great for women. One of the studies was the ALTER trial, and it showed that it was non-inferior compared to antibiotics in preventing UTI. So it's quite effective. Sadly, we do have also the SIMBA trial that showed that methenamine was not better than placebo for somebody with a spinal cord injury. And many of those residents, they have catheters. And the problem is that methenamine has to stay in the bladder and change in order to do its action. So really empties too quickly before it can do its action. So maybe won't be the best for somebody with an indwelling catheter. The other one is cranberry. There's a meta-analysis from Cochrane, systematic review with 26 studies. It shows that is quite effective. The relative risk is 30% lower if you use cranberry. So I encourage people to use it. The only caveat is when they analyze the group of older patients, older than 65, they couldn't find a difference. But at least in other groups it does, and it doesn't have a lot of side effects. So if people want to try it, I do tend to encourage it. Finally, D-mannose, it doesn't allow the bacteria to attach to the bladder. The data is still out there. We're not sure if it does help or there's no evidence to support or refute D-mannose at this time. But mainly to show you that you have options before going to the nuclear option that is having somebody getting antibiotics every single day of their life. In some people, we do have to use that, but hopefully you can spare a lot of your residents unnecessary side effects from antibiotic use. And you can use here at ASAP, we have an audit that you can work with your consultant pharmacist to, hey, have you tried these options before antibiotics? And if you're using an antibiotic, have you cycled them? What dose are you using? So you want to make sure that you make the best informed decision for your resident in order to improve outcome. So, and finally, for UTI, this is my last slide. Um, Treatment goes beyond the scope of this talk, but in general, shorter is better. These are two resources. One is from Nebraska Medicine, is their clinical pathway. And you can see for UTI, they give you options, and it's between 5 to 7 days for most antibiotics. And the other one is from Brad Spellberg. He's an infectious disease doctor from UCLA. And he has a website called Shorter is Better, where he puts all the studies showing that a shorter course is safe and effective. And you can see for complicated UTI, it's difficult to read on that, but 5 to 7 days is non-inferior compared to 10 to 14 days. So really, you shouldn't be seeing courses of 10 to 14 days in your facility. So this was UTI. Let's go now to our next pathology. This is going to be respiratory tract infection. So with respiratory tract infection, I think we need to talk about a couple of things. One is what is upper respiratory, what is lower respiratory. Um, Normally, we call upper respiratory to the level of the larynx. So anything up like sinuses, nasal cavity, pharynx, larynx, that's going to be upper airway. But anything below, going from the trachea down to the bronchi, going down to the lung, that's going to be lower respiratory infection. And on the other side, I listed the symptoms usually associated with upper versus lower. And you can see that upper, sometimes you see things like runny nose, you see sneezing, you see sore throat, swollen lymph nodes, and in lower respiratory, you see shortness of breath, you see sputum production, you see hypoxia, so lower oxygen. But there's a lot of symptoms that go between that can be seen on both of them, mainly cough, maybe myalgias, so body pain, fever can be seen with both. So really, you cannot rely sometimes completely on symptoms to rule out disease because some of those will be shared between upper and lower respiratory infection. Um, Another way to think about respiratory infection is to think about syndromes. So not just anatomical location, but rather the common syndromes. For example, sinusitis, inflammation of the sinuses, 98% is caused by viruses. Really, we shouldn't be seeing antibiotic being used for sinusitis. In very few exceptions, when they don't improve and they have a rebound and with higher fevers, maybe you'll use antibiotics, but in most cases, no, no need. Common cold, that's going to be viral. A strep throat, um, requires a diagnostic test. The other syndrome is laryngitis. It's usually part of the common cold. Um, so mainly viral. You shouldn't be using antibiotics for laryngitis. Bronchitis, that's inflammation of the bronchi. And this one is very important to distinguish between pneumonia, because bronchitis and pneumonia both will have cough, both will probably have a sputum production, both may sound junky when you listen to their lungs, but one is 90% viral, the other one is 75% bacterial. So the main way that you distinguish it sometimes is just with a chest X-ray. Chest X-ray is clear, I'm stopping antibiotics and just monitor my resident clinically. But if I see infiltrate, then maybe I'll keep the antibiotics and see how it does. Uh, so let's go with a clinical scenario. It's mid-December. After your success improving UTI, you're now turning your attention to respiratory infections. So Nurse Summit mentions that Mr. Bennington, he's a 72-year-old man with early Alzheimer's disease. He now has a fever of 101. He has body aches, chills, runny nose. He has a dry cough, and he has some sinus pressure. So remembering some of the anatomical location, you say that sounds upper, right? He doesn't have hypoxia. Dr. Stewart listened to his lungs, they're fairly clear. The oxygen saturation is good. What would you do next? You would avoid antibiotics and provide supportive care. He'll improve on his own. Anybody, would you do that? I see some hands. Uh, um, I want to use Love's minimum criteria for upper respiratory infection. That exists, right? Sadly, no. Um, you liked Love's because it was so useful for UTI. Um, but good news, there's a Love's criteria for lower respiratory infection. You want to do a chest X-ray to rule out pneumonia. Anybody would do that? No. The symptoms are more upper. But maybe you want to use surveillance definition. Would you use that? Not sure. I would say maybe you do. This time is something that I would use McGear because I want to differentiate between a common cold or influenza-like illness. Because if I have criteria for influenza-like illness in my facility, I do get worried. So I want to investigate what's going on. And if I do the analysis, I see that my patient had fever, had chills, had myalgias, had malaise, had new increased dry cough. So I have criteria for ILI or influenza-like illness. And what do I do? I have Mr. Bennington. It's mid-December, so I know influenza season. So I test him for influenza and he comes back positive. And now I really changed the way I'm managing things in my facility because I start Mr. Bennington on antiviral medication, also Tamiflu or Tamiflu, because I know that residents in my facility, especially older patients, are at higher risk of a bad outcome from influenza. I put him on droplet precautions because I don't want this going around my facility. And I'm going to start testing those exposed and those with symptoms. So now you really have a change in management. And now because you use surveillance criteria, so it's not all black and white. Sometimes you use clinical criteria, sometimes surveillance. It's really honing the tools that you have and use them on the right scenario. So 2 days later, his roommate starts developing symptoms, and now you have two cases within 72 hours, and one of them with laboratory confirmed influenza. Now I'm making some decisions quickly. So I'm calling this an outbreak, and I start treatment promptly for anybody who's symptomatic, and I start chemoprophylaxis for all my patients in that unit, and I continue until 7 days until I don't see any more cases. Um, and you limit any large group activities. So now you saw how much you change management just by doing some simple criteria that really change things for your facility. So let's go back to our clinical scenario. After managing your last influenza outbreak, you partner with your consultant pharmacist, and you want to do a line list for residents in which you have their weight, you want to have their renal function, because every time I need to use Tamiflu, I need to know that. So I don't want to be in a hurry trying to figure that out whenever that's happening. So I do that, and I also implement a very strong vaccination program, including for Miss Patrick. She is a 66-year-old woman with diabetes. She has hypertension. She has heart failure. She has rheumatoid arthritis. And she very happy received her flu shot 2 weeks ago. So over the past week, Miss Patrick has developing worsening productive cough. So when you see the sputum, it's kind of a frothy, clear sputum. She's having some shortness of breath. Her oxygen saturation is lower, now it's 89. And she's now sleeping propped up with multiple pillows. She doesn't have a fever though. And you ask her about has she been with any ill contacts? No, she said no. But I've been out with my family every single day. They are in town, so we're enjoying the local food scene. It's been nice. So you call Dr. Stewart, and this time he's not very stewardy. He gives her moxifloxacin, a quinolone. We don't like that, and 14 days. So, what concerns do you have about this situation? Anybody has any major concerns about that? Yeah, so it sounds long. Sounds like the wrong antibiotic. Do we have even the right diagnosis? So I decide to use my Lowe's minimum criteria. I told you there's one for lower respiratory disease. So now you use that one. So my situation is I'm concerned about a lower respiratory infection. My patient doesn't have COPD, doesn't use supplemental O2 at home. She does have a history of heart failure. Um, and she didn't have a history of lower respiratory tract infection over the last 6 months. She has diabetes. She has a penicillin allergy and is a headache. The consultant pharmacist here they're cringing about that. So you take the vitals. Blood pressure high, but overall okay. Heart rate is 110. She's afebrile. She's saturating 89%. And you see Loeb's criteria, and you see that she has increased cough, but it doesn't have purulent sputum. So it doesn't have that one, and the respiratory rate is more than 25. So technically, doesn't meet criteria. So you say protocol criteria not met. So you send it to Dr. Stewart. So he reviews and decides to contemplate his life decisions. And he says, no, maybe I'm not going to do 14 days of moxifloxacin. I'm going to do an x-ray. I'm going to keep an eye on her eye and nose. I'm gonna weigh her, and I'm gonna do daily weight, and I'm gonna give her some Lasix. And after a couple of hours, he knows that he discovers that she increased 10 pounds over the last 5 days, and she's been eating deep dish pizza with her family, and eating very salty food, and she has heart failure exacerbation. So this is why having some criteria is so useful, because it really sounded like it could be infection, but these kind of forces you to go through the aspect of analyzing the case. Sometimes we have what is called diagnostic momentum. That's when somebody mentions a diagnosis, it's very hard to take it back. The first doctor says pneumonia, then the second one says pneumonia, and the third one says pneumonia, and pneumonia it is. Like this, many times it's not. So What are some of the recommended workup for lower respiratory tract infection? Usually a CBC. You want to see if they have leukocytosis. If it's influenza season, I'm testing for influenza. You know how it changed my management. Um, COVID is here. COVID is still here and it's not going to go anyway. I'm going to test for COVID. If you have access to Legionella and strep pneumo urine antigen, you can test that. A chest X-ray is going to help you differentiate between, for example, bronchitis that is 90% viral versus pneumonia, and also might show things like um, the pattern of an X-ray with somebody with heart failure is different sometimes, many times compared to somebody with pneumonia. And having a sputum culture, if you can get one good quality sputum, is going to be essential. Um, what about duration of therapy? We had our Dr. Stewart who initially wanted to do 14 days. Really, that's not ideal. I'm going to mention a couple of studies. This one is from France. They did it at 51 ICUs. Um, and they took some of the sickest patients that we see, those with ventilator associated pneumonia. So in the ICU with a ventilator, this is the kind of patient that you don't want to miss. Um, so if somebody was on a ventilator for at least 48 hours and they had a new infiltrate on imaging and they had signs of infection like fever and leukocytosis and a positive sputum, and they recruited 400 patients. And what they wanted to compare was 8 days of antibiotics compared to 15 days. Many of you who have worked in acute care before, maybe you remember that it used to be that if anybody with ventilator who had pneumonia, it was immediately 2 weeks. So this was challenging that notion. And what you can see on the curve is the probability of survival. And if you can see that two lines are pretty much the same. So 8 days is non-inferior to 15 days, so it's pretty safe. Um, this one was another study, and this is more specific for seniors. So this was in 70 US centers. They wanted to see people with a new infiltrate who had symptoms of pneumonia, and they were able to recruit 177 older adults. And what they wanted to compare was levofloxacin with a little bit of a higher dose, 750 milligrams for 5 days compared to 500 milligrams for 10 days. And what you can see there, where it says all patients, 89% of those who received 5 days had a clinical cure compared to 91%. So there was no significant difference. So now we have one study comparing 8 to 15 days, showing 8 days is safe. And we have this one comparing 5 to 10 days, showing 5 days is appropriate. So now we can extrapolate that for your facility and say, hey, duration of therapy, 5 to 7 days is appropriate. And what antibiotic would you use? This again from AHRQ. The same bacteria that you see outside in the community are going to be the same culprit in your facility. Things like Marcella catarrhalis, Mycoplasma pneumonia, things like strep pneumo, nothing fancy for most people. So for most, you can use something like amoxicillin clavulanic acid, or you can use Unicin or ampicillin sulbactam. You don't have to use something super broad spectrum. Um, and you should add some atypical coverage, something like azithromycin or doxycycline. So that's going to be very narrow, and it's going to really make a difference if you apply this to your facility, because we see way too often broad spectrum antibiotics. We see them with carbapenems because ertapenem is only given once a day, so that's nice. Or we see them with quinolones, and we're really making a lot of damage to our residents when we can use something much narrower and get great outcomes. And in red, you can see not all people are the same. Some people do require broad spectrum antibiotics, but it's mainly those who had a recent exposure to antibiotics, or were recently admitted to the hospital, or are known to be colonized with an MDRO. Those are the people that need a little bit broader spectrum. So one of your residents was diagnosed with a lower respiratory tract infection with Mycoplasma pneumonia. He was treated for 5 days with antibiotics. Since completing the treatment, he no longer has a fever. His oxygen saturation is normal. His white blood cell count has returned to normal. He's feeling well, actually. But he still has a dry cough. That is not going away. And it's been 2 weeks, and his family is upset. They're calling you all the time. The cough is annoying. So now you have some pressure. What will you do? Would anybody repeat an antibiotic course for 5 days? Because 5 days is too short. No, we know the data. We know that's not it. Would anybody repeat an X-ray? Maybe there was something else. I would argue against that because X-ray, sometimes there's a delay in resolution. So somebody can, no longer have an infection and it still looks like a pneumonia. So I wouldn't repeat an X-ray. What about sending him to urgent care? That cough is not going away. Somebody should do something. No. Everybody is very stewardy today, so they want to reassure the patient and the family. And why do we do that? This study is nice. This is about duration of cough. It was mainly done in primary and urgent care centers. And what they wanted to do is people with lower tract infection who had cough and at least one symptom suggestive of lower tract infection, like shortness of breath, sputum production, body aches, fever, chills. Um, and they wanted to see what is the difference between cough duration. And they tested them with cultures and PCR panels, and they were able to recruit 718 adults. And what you can see highlighted is that the average duration is more than 14 days, so 2 weeks. And you can see that for viruses is 14.7 days, for bacteria is about 17 days. With no detection of any organism is about 18 days. So that's kind of curious. The ones that we don't find anything is the one that is a little bit longer. And you can see the 90th percentile. So we know that when you have a normal curve, most people tend to be around the mean. So, but there's some people that where the duration of cough is longer, and those in the 90th percentile, they can have about a month of coughing, and that's still kind of part of the process. So nothing that you can do except for some supportive care is going to make too much of a difference. So I would reassure my patient, I would reassure the family, it's going to get better, but no antibiotics, please. So, final topic. I know it's a lot of information I'm throwing to you today, so let's go through the last one. This one is a little bit shorter. So now we're going to talk about a skin and soft tissue infection. And this is another one that I think we need to take a look at the anatomy and the structure to kind of understand really what kind of infection we have. So there you have a picture of the skin where you have the epidermis, that is the outermost layer. You have the dermis, and you have the subcutaneous tissue. So it depends on where the bacteria is located to see what kind of infection you'll have. If it's on the hair follicle, that's what we call folliculitis. Sometimes you can see it in things like hot tub folliculitis with pseudomonas. Um, that is a very superficial infection. Many times they don't require any antibiotics. Things like impetigo. Have you seen those kids that they have crusting and it looks like honey? That's a very superficial infection, mostly caused by Staph aureus. Um, then you have your abscesses. Those are the furuncles and carbuncles. That's going to be a deeper infection. And when you have cellulitis, and that's what I want to focus most on this talk, that's going to be the subcutaneous tissue, the dermis, and the epidermis. And you know that you've seen that resident. It looks bright red, angry, it's painful. So it's painful because it's really affecting every single layer of the skin. So with that, uh, here we have a picture of cellulitis. You can see that it doesn't have a very good border. It's very red. And the organisms that typically cause cellulitis is going to be your skin organisms. Staphylococcus aureus is going to be your group A strep. Is going to be other streptococcus. Some risk factors for cellulitis is going to be obesity, It's going to be venous insufficiency. And that's what I see the most as being misdiagnosed as cellulitis is what we call stasis dermatitis because of venous insufficiency. It's going to be your patient with lymphedema. It's going to be the patient that have fungal infections in the toes and the nails. That's going to be a port of entry for cellulitis. So some people don't treat that, and that can be sometimes a very big risk factor for cellulitis. And skin trauma is going to be another one. Um, Cultures rarely help. I wouldn't get blood cultures. You're usually not going to get any. So hearing the first talk about diagnostic stewardship, this is a great intervention to make sure that they don't send blood cultures because of cellulitis. Um, Skin culture is usually not helpful. When you swab the skin, you're going to get whatever's on your skin, not necessarily what's causing the infection. And one of the main concepts that I want to drive is that when you don't have pus, when you have this kind of redness that is diffuse, most often is streptococcus. So you don't have to cover for staphylococcus. So staphylococcus, I would reserve coverage for my very, very sick patients or those who have an abscess and collections and pus, because that's the one that you're most likely going to grow staphylococcus and often MRSA. So this is the same picture of cellulitis. What do you notice? Is red, is hot. One of the things that I see the most, because I told you that a common confounder is venous insufficiency. If I lift the leg of somebody with venous insufficiency, the redness tends to go away. That's not going to happen with cellulitis because cellulitis is affecting every single layer of the skin. So you can elevate that all you want. It's not going to make too much of a difference. So the border is kind of irregular. Sometimes it's kind of dimpled. Sometimes you can have what's called bullae, those kind of bubbles with fluid. Sometimes you can have cutaneous hemorrhage. So you see blood in those kind of bubbles. Itchiness is kind of rare. So if anybody has itchiness more than pain, I tend to look for other diagnoses. And please, single side. That's a lot of times I get called for cellulitis on both legs. I I don't think I've seen one that is a real one because it usually affects only one side. Because if there is a port of entry, why would it affect two sides? It can happen, I guess, but it's not common. So if I see somebody with two erythematous legs, I'm thinking something else, like venous insufficiency. Um, Good news, you do have Lowe's minimum criteria for antibiotic. So here are two scenarios. One is purulent drainage from a wound. That's going to be an instant uh, check on your criteria. And the other one is more for the streptococcus cellulitis. So you want at least two symptoms. You want to have that redness. You're going to have that warmth. You're going to have that swelling. You may have fever. You're going to have increased tenderness. So you can use that to guide your diagnosis. Um, Lastly, I want to show you this. This is from Nebraska Medicine. Is the recommended treatment for cellulitis. And here you can see for non-purulent cellulitis, we should be using things like Keflex, like cephalexin, cefadroxil, because we're aiming for streptococcus. For severe disease, you may use something like linezolid, but I want you to keep an eye on the duration of therapy, 5 to 7 days. So you shouldn't be seeing those 10 to 14 days for cellulitis either. So that's a great way to take a look at your facility and see what people are doing with duration of therapy. The last one is purulent cellulitis. Um, this one is the one that you want to cover for staphylococcus. So you want to use maybe Bactrim, doxycycline, things like that. And if you have an abscess, common belief was that you only have to drain an abscess. You don't have to give antibiotics. In most cases, that's true, but there have been a couple of studies, one of them published in the New England Journal of Medicine, that there's a little bit faster resolution and less relapse if you use antibiotics. In some cases, like severe extensive disease, if the abscess is more than 2 centimeters, if somebody's immunocompromised. So those are the people that you may want to think in using an antibiotic after you drain an abscess. Um, and I love this prevention over treatment 1,000 times. Just like urinary tract infection with vaginal estrogen and methenamine, I want to do the same for skin. And one of the things that you can do, this was a very nice study from Australia, where they wanted to see if they could prevent cellulitis using compression stockings. So it was a single center study. And they recruited people that had at least 2 episodes of cellulitis over the last 12 months. So they have recurrent infections. They were able to recruit 84 patients, and they decided to compare compression stockings to just educating the patient. And you can see the y-axis is showing the percent of participants that are free of any infection. And you can see the people using compression stockings are really staying up there free of recurrence compared to the ones that just use education alone. So I would think about that for your patients that are using antibiotics for skin infections frequently. That's a great intervention that you can do. And you're sparing antibiotics. So, and think about the mimics. Think about the things like look like cellulitis, but they're not. So, stasis dermatitis, if you have a blood clot, that's going to be red, that's going to be swollen. If you have lymphedema, if you have contact dermatitis, if you have very severe allergy, it's going to look like an infection. If you have eczema, so not everyone needs an antibiotic. Your Loeb's criteria to try to distinguish those who don't. Okay. And that is the end of my spiel about infections. So now we can go